Should have been underneath. COVID-19 coordinator at Bethesda Hospital. David Bridgman, the head of Anaesthesia at Joondalup Health Campus. He's the good-looking chap on the left as we look at the screen. And then Jonathan Chambers, who's the good-looking chap on the right as you look at the screen, the Infectious Disease Physician from Joondalup. And so I'm not going to spend a lot of time talking about bios and things. We did send that information around. I really wanted to get into there's been an awful lot of interest about the preparations in not just the public, but also the private hospitals in Perth. Thanks for that, Jonathan, that's a better angle. And the three of you have been heavily involved in all of that, and the Joondalup cases obviously were famously the first big batch to come through, so we'll talk about those. But I also wanted to bring in Silke's perspective from her facilities, and having set up an excellent preparation as well at Bethesda, just to broaden things out a bit as well and bring in her expertise. So without much further ado, I guess I'd ask David or Jonathan to give us the I suppose anecdote around how you found out that you were getting a bunch of Artania patients, how much notice you had, and what preparation I suppose you had in place in your facility, what thinking you'd been doing before those events of a few weeks ago.
We might put the slides.
Slides up. Who wants to go first on the slides? All right then. Can you share the slides for us, Lizette? You start, Jonathan, and we'll catch up with you on the slides.
Yeah. So as this suggests that basically on the 27th of March at 8 o'clock at night, I got a phone call from my boss, Andrew Wesseldine, to let me know that we were about to take all of the Artania passengers that were obviously in the news. And so the very next day in the morning at about 10:30, they all arrived under some agreement that I'm still not 100% certain about. But basically a bunch of passengers walked in. I was up on we have a special ward that was purpose built for pandemics. And I was up there when they walked in, and they looked extremely well when they came in, but that's not really how they remain. Oh, I'm not in control of the slide, am I? Can you move on to the next one? And so, I mean, this is a summary of, this is basically a one-slide summary of what happened at Joondalup Hospital. So we had 29 Artania patients, but we ended up with a few more, and we ended up in total with 43 patients over the course of about 2 to 3 weeks. We had over 3,500 individual patient contacts in personal protective equipment, and we basically followed guidelines that are kind of the precursor to the current guidelines that are used for West Australian Health Department hospitals. We had 10 admitted to ICU, which all required intubation. We had 3 patients that had pulmonary embolus. We had 3 deaths. And at the end of it, and it's now over 21 days, it's longer than 21 days to be honest, since our last patient left or was cleared. And we haven't had any known healthcare worker associated infections. And saying that, there is concerns about asymptomatic infections. Obviously, that comes up frequently, but if we did have that amongst our staff, we should probably have had some further problems, which we haven't. So we're pretty confident that we did all right and we did it safely. And maybe Dave wants to talk about the anaesthetic and ICU experience a bit more.
Yeah, so we're very lucky in this hospital. As a private hospital, we have a salaried department. So we had the ability to prepare using salaried anaesthetists for quite a long time prior to them arriving. And I think we'd probably been preparing for about 3 or 4 weeks beforehand. Just getting all processes involved about theatres, but also we'd set up an intubating team. So we had a core group of sort of COVID anaesthetists who had arranged all the policies, etc. Did a brilliant job in sorting all of that out. So we also had a group of sort of educating anaesthetists who had run simulations many times in order to get everyone ready for it. We still were expecting a normal admission process though. We were expecting, sort of 2 or 3 patients and then another 2 or 3 and a slow sort of build up. So the anxiety, I think, was there initially, was just waiting for that first patient. And then we went from no patients to 29 patients with an hour or two's notice, which, yeah, was quite challenging initially. So we basically, we just dealt with it as it happened, essentially. So as John says, all these patients walked into the hospital. They literally were on a bus. They walked off that bus up into the ward and were just being nursed on the ward as normal. Within 24 hours, 3 of them had been intubated. So all the talk about the well-looking hypoxic patient was absolutely true. One of them actually got admitted to the ward, and when the SATs monitor got put on them, he had SATs of 77. So he was one of the first ones to be intubated. And I think that's what took everyone by surprise, was the speed at which they sort of deteriorated. It all fitted in though with what the advice that we've seen worldwide was that sort of day 5 to day 7 post-infection, they actually dropped off the edge of the cliff and fell into a big hole, which is exactly what happened. So we then went from 3 intubated patients in 24 hours to, I think it was about 4 or 5 within 48 and 9 within 4 days. So that was the big learning experience really from our hospital, I think, was how to actually deal and cope with that. We also did have one other patient, actually the day prior to the Artania patients, who was from the Ruby Princess. And he was slightly different. He presented with myocarditis and profound cardiogenic shock. And he actually died within 24 hours, just a pure myocarditis and intractable cardiogenic shock, which was a big surprise to everyone. And I think his viral load was the highest that anyone had actually seen when the PCR came back, is what I can gather from there. So we just basically dealt with it as we could. I think it was a big eye opener, and it was very useful for our hospital though, because if I could say to everyone, it's actually sorted out all of the anxiety and fear within the hospital. We now realize that you can look after these patients fine. They have a viral illness. If you wear the correct PPE, as we mentioned there, 3,500 contacts and no one has caught it. If you wear the correct PPE and do it properly, the patients can be nursed properly. And if you wear the correct PPE and intubate them in a sensible way, you can avoid any other issues in catching the virus. And that's what we did. So I think it was just a testament to the whole hospital setup, and that we were, even with the preparation we had, we did manage to do it.
One of the things that we probably also need to mention is that so ICU over the course of five or 7 days was very much overwhelmed. Like the number of patients that were ventilated, I think with COVID was 6 at one time, and that all happened within a week of them all arriving. And so that did put the system under a great deal of pressure. We did have to change to an airborne isolation unit in ICU, which was relatively successful. But obviously, now that we've done it, we know how to do it better, because there's obviously problems when you've never done this before. It's quite challenging to look after these high-level care patients in ICU, and particularly working out how to get in and out of PPE and where to sort of the logistics of it is quite challenging, and we learned a lot. Unfortunately, as fast as the tap was turned on, the tap was turned off, so we didn't have the persistent onslaught that you obviously can see in the UK and Europe and America. So we're kind of lucky that we got to test our system and then turn it off, and we're kind of able to review everything and change things that aren't working, which also includes me trying to half redesign the entire hospital to executives' great pleasure whenever I ask them about things. But the other thing not to forget is that there's the critical care side of things, but the actual logistics of running an isolation ward is really quite complicated, and I know it sounds like we always prattle on about multidiscipline teams, but this was a real true multidiscipline team approach. We had infectious diseases physicians involved. The respiratory physicians were basically looking after the patients. General medicine was involved in looking after a lot of the patients and then taking them from the respiratory physicians where they were stable. We had the infection control nurses were up there almost every day. We had catering and cleaning staff being trained in how to use PPE properly, and also putting policies in place to handle all of the food trays, the washing, the cleaning, the everything, which is all, to be honest with this, PPE is very, very important. But the environment and the planning and the cleaning and the infection control that is also behind managing these patients is equally important for this virus, because as you will probably know, it's viable for 90 hours plus on impermeable surfaces like this table, which our hospitals are very well designed in full lino and plastic and stainless steel everywhere. And so almost these if there is a significant amount of virus and you're not doing appropriate cleaning and you've not got a good policy with your catering, you might run into problems. And we're very lucky that we kind of had a good team working together. And it's a funny thing because respiratory physicians and ID physicians are not usually considered. I know I'm talking to lots of anaesthetists, so you don't usually understand the ins and outs of physician-y stuff, but respiratory physicians and ID physicians are not natural bedfellows. We kind of don't see eye to eye sometimes with antibiotics and things, but in this case, the respiratory physicians did a fantastic job running this ward, and I think collectively we did a reasonable job, and we continue to run a COVID isolation ward for suspected patients, and we're ready for the next sort of wave if it happens. And we've still got the same thing. We're doing a meeting every day, which can be a bit tedious probably for the respiratory physicians talking to me, but we're still keeping some of the existing platform in place.
That's it's terrific for you to set the scene like that, and lots and lots of questions coming out of it. What was the age range of the patients? You've got the age of the ones that died. They're all in their early to mid 70s. What was the youngest and oldest? Do you have those?
I think the youngest were in their 60s, so sort of mid 60s, but most of them were over the age of 70.
Yeah.
There are a few close to 80 as well.
So pretty much the
exact ages.
Cruise ship demographic then across the board there.
Sorry, I forgot about the crew. There are some crew members that were in their 30s and things like that.
Okay.
So about sort of roughly of the 30 patients, roughly about 10 of them were crew, and 20 of them were elderly German nationals.
And if the went to ICU, were they all elderly?
Yes.
Yeah, they were all over 70 in the ICU.
Okay, so the mortality rate of 3 out of the 10 that went to ICU is pretty impressive compared to some numbers that we see. It's obviously a small sample, but we quite often hear the figure of 50% once you hit the ICU. What's your feeling when you looking at the reports from around the world? Obviously, when systems get overwhelmed, the mortality jumps. But what's your feeling around the likely mortality rate in our system if the system's not overwhelmed once they hit the ICU?
I guess that's the question that everyone wants to know the answer to. If you look at the other hospitals around town, I was speaking to a couple of the ICU guys around town, and it's around the sort of 25 to 30% mark. That's with a very small patient group, I suppose. But yeah, I think exactly as has been mentioned, the mortality rate is dependent on the overwhelming side of the actual health service. What we found in our ICU was that there were a couple of nosocomial infections, for example, which our ICU had never had before, and in sort of 3 or 4 years, I'd never had a line sepsis for a line put in on ICU. They then got one in this case. There was also one ventilator-associated pneumonia, all of which were actually able to be dealt with because the patient stopped. So the ICU guys had a chance to sort of have a look at the way that they could look after these patients. Proning was they started to use proning. They were able to change the lines very rapidly once they had these infections, which I think that those are all the sort of things that would disappear and not be possible when your system is overwhelmed. So I think that is the example of what's happening in Italy and Spain, is that their normal processes have gone out the window essentially, and they can't actually manage to do the care that they normally would.
It's not true intensive care that they're providing in the meaning that we understand it. It's kind of triage rescue manoeuvres. I'd just like to bring Dr. Brinkmann in, and because looking at the way this was handled, and this is a quasi, public hospital really in the sort of infrastructure and the salaried anaesthetists who were able to be there setting things up beforehand. How does it make you feel, Silke, when you are you sort of pulled this all together in a smaller hospital, which is an excellent facility, but what are the special challenges you've had to face as compared to this hospital, which we made a judgment call on the day at the AMA that they were the ones who were ready, and look, in retrospect, it's looking like a good call. How do you feel about the small facilities getting prepared?
Yeah, look, great success story at Joondalup, and certainly unique challenges with a smaller institution and a completely sort of private institution. Jonathan, when you mentioned that your hospital had a sort of pre-existing pandemic ward, that made me smile, because there's not many hospitals around town that have that. So, with the absence of a pre-existing sort of defined ward, absence of a salaried department, no negative pressure rooms, and no sort of active multidisciplinary workforce, we had to be creative and be agile and work quickly. I'm also an anaesthetist at Charlie Gardner, and had the great benefit of doing a lot of their training and preparation similar to Joondalup in the weeks prior to Tania arriving. So it was very much at the forefront of my training and awareness of what was going on. And then I was asked to sort of come on board, if you like, pardon the pun, with Bethesda after the Tania cruise ship patients arrived in Perth. And that did mean a significant amount of work and overcoming some challenges, but it's been a journey of which I think has led us to be quite well prepared to sort of support the system in Western Australia if we are asked to step up and look after COVID patients. So a huge amount of learning, great collegiality, and very appreciative from our colleagues at Joondalup, at Charlie Gardner, and other hospitals around town that have helped us with pre-existing guidelines. And I think of note, one of the important factors is something that Jonathan touched on earlier in sort of the hierarchy of hazard control, in that PPE is really the pointy end of it, and PPE is something there's been a lot of focus on. But hazard control more broadly includes administrative controls and engineering controls that where policy and protocol is extremely important. And Bethesda had put a lot of work into their policy and protocol development over time, and even though we didn't have that sort of on the ground stuff in place in the early days, they had sort of a really great team on board with developing those kind of administrative approaches. And since then, as you know, Andrew, we've put together a pretty active team.
Yes, and how do you see the role? Look, talking that top level of the hazard control, how do you see the role of the smaller hospitals as compared to the flagship ones like Joondalup?
Yeah, so I mean, look, much more, a few unique challenges in us sort of implementing, for example, COVID wards and cohorting patients as such, and trying to redesign our, you know, for example, from an engineering point of view, there's been a lot of effort put into thinking about our ventilation systems, and you know, redesigning infrastructure really, some of which is possible, some of it which is not. Even in a hospital such as Charlie Gardner, an older hospital that doesn't have the same perhaps capacity to provide isolation wards and negative pressure, you know, similar to the new places like Joondalup and Fiona Stanley. So we've had to just redesign on the fly. And it's been a huge challenge because existing hospitals aren't sort of necessarily designed to be able to pivot to address, you know, or reconfigure themselves to address pandemics very easily. But, you know, a lot of work in simulation, training, and policy development to keep both, you know, patients safe and healthcare workers safe has been the key.
And you wouldn't anticipate having a lot of ICU-dependent patients staying at Bethesda, though, presumably, so the role would be more to the strengths of the facility.
Yeah, again, that's been very much on a policy development sort of level, and Bethesda has and will continue to try to support the COVID response in taking appropriate patients within the capacity that we have. So we may not be known to everyone, but Bethesda's had for a long time a really robust and well-respected palliative care unit. It has 25 beds and caters for both public and private patients. This is an area that's been identified as a possible, you know, place where we could really support the West Australian community in COVID patients who happen to be palliative. So our team, led by Paula Moffat, who's one of the palliative care physicians, is, you know, sort of actively preparing for that. And then, you know, we've also planned for any surge capacity and tried to plan for patients who, you know, may become COVID positive, or if for example, the public or tertiary system is overwhelmed and they need our support. But we certainly see our patients as being, or our response as being, to cater for the palliative patients on our palliative care unit, and then provide further surge capacity if it's required in the event that things become critical. And if that happens, we've got you know, an experienced team. We're simulating these you know, potential events and hoping to act accordingly. And again, not planning to, you know, have an on-site ICU, because that's well beyond our capacity right now, but be able to look after a deteriorating patient, escalate care, and hopefully transfer to a more appropriate facility. So that's where we see our, you know, role as being.
And I think that will apply to a lot of the smaller facilities to provide that support. And I think palliation is clearly in a large epidemic, something that possibly gets kicked down the list a bit in terms of priorities, but is going to be, in fact, you know, make an enormous difference to large numbers of people if we were to get big numbers of cases. We'll just go to the next slide and ask Jonathan to run through the rest of his slide pack here and tell us what we're looking at.
So this is one of the wards that we set up as an isolation ward. This is actually, we've got 3 wards that we kind of set up in anticipation. The top floor, L2, is our isolation ward that's actually all under negative pressure, and this is kind of similar. This is the bottom floor, but you can see that we basically created a dirty and a clean zone. The nurses station and everything's in the clean zone. All of the storage areas and all of the PPE donning stations are all in the clean zone. And then using relatively well-established PPE preservation guidelines it meant that staff members could walk between rooms in the dirty area, preserving masks and goggles if they were not soiled and still appropriate. They could wear the same gown as long as they replaced their gloves and did hand hygiene again, as long as the gown was not soiled, and they didn't have heavy contact with the patients. And so you're able to basically create half of the ward as a dirty area that the staff could move between. I personally trained the phlebotomist because I'm also one of the Western's microbiologists. So myself and Gahin Lee trained the phlebotomist how to do swabs and how to do it safely as a sort of a buddy team and fill in the forms properly at the same time and things like that. All the little things that you don't really think about, but you could keep a phlebotomist clean on one side and you can keep one dirty doing the collections on the other without wasting PPE. So there was a degree of learning as we went, but we kind of learned a lot of lessons setting this up. Maybe go on to the next slide as well. I can't remember what the next one is. And this is sort of what I was talking about before, like all of the bits that we had to sort of coordinate, and there's many more things on there. The engineering, which Silke's touched on, is absolutely critical. Getting all the airflows correct, making sure that the testing has been done, making sure that there's a strong. We're lucky in Joondalup, and I'm kind of talking myself up when I say it, but we're lucky at Joondalup because there's quite a strong relationship with Westerns and Ramsay, and I've worked for both of them, and it's kind of almost like an integrated job. There's not many integrated microbiology and ID jobs left, but it does make things work a lot smoother when you've got that integration in this sort of setting, because it means that we just smoothed over lots of issues with the lab and made sure things happened, the testing happened, the swabs got collected and all the things got done. Maybe move over to the next slide. I think that might be the last one. There's a couple more pictures. So this is the standard room. You'll notice on the first picture that there's carpet. ID physicians hate carpet in isolation rooms. They hate them generally in hospitals. You can't clean them properly, but at least the rooms are all lino and they're nice and easy to clean. And so they're pretty good standard hospital rooms with lino floors, but under slight negative pressure. Go to the next slide. And then this is basically all of the things that we've been talking about. Our biggest issue at this hospital, and still continues to be the issue that we deal with every day, is morale and anxiety and fear. I mean, one of the things that I've been forced to do is take a much more proactive sort of speaking role and doing lots of talks and updates and things with staff to try and tell them, both educate them about why we do things, educate them about what's happening with the virus, educate them on the evidence behind all of the things that we do. And I think that's been useful. I have odd people saying, "Hi, Jono, thanks for your talk," which is nice. People that would never say hello, but there's an important education thing that you need to make the most of to try and quell people's fear. Looking after the patients has definitely helped, but we still needed to explain everything as clearly as possible. When guidelines come out, to get the guidelines and try to expose people to them as soon as possible and explain them rather than shock them, which we've all experienced so far and still continue to do so.
Let's just address that for a minute, because it's obviously an issue of great interest and contention is the PPE, because I think talking about this anxiety and fear, the way I think about it is that if you've tested everyone inside the facility and you know they're all negative, then that's like having metal detectors at the doors. But if your PPE is more like a bulletproof vest, so it's something that you can see and touch and you know it gives you protection. What exact PPE were the staff using in the dirty area and the clean areas?
So in the clean area, patients were wearing scrubs, but they weren't routinely wearing masks or anything like that, or gloves. They were just wearing hospital scrubs, and they were doing hand hygiene between handling notes, so standard general precautions on the ward. But in the dirty area, the staff had the standard. So this is for the medical ward where the patients weren't unwell, but obviously they could have become unwell. But for the patients that were well, they had face shields, a surgical mask, or eye protection, as well as a full long sleeve gown and gloves. And they changed the gloves and did hand hygiene before patients. And I think, Andrew, you know that I always say that the most important aspect of the PPE is actually hand hygiene is absolutely critical. And it's one of the things that falls down all across the world, and has fallen down in lots of countries, because people forget how important that is. That's the only thing that kills the virus. The PPE stops it, but it doesn't kill it, whereas the hand hygiene does, whether you wash it in a basin with soap and water or you wash it with alcohol. But that's essentially what we did. And then we did bring in, so at that point, the guidelines were different to what they are now. So it said if someone had symptoms consistent with severe pneumonia, then it was meant to be airborne precautions. So with patients that did look like they had severe pneumonia, then people wore an N95 mask instead of the surgical mask. But we added an extra. It was quite difficult in many cases to work out what that actually was. So the guidelines say something, but they didn't actually define clearly. They said lots of things about coughing frequently, which is easy, but they didn't really define what that was very clearly. So we had to put some additional things. So if they required oxygen up to 6 litres per minute on a Hudson mask, then we said, okay, well, that in our experience now suggested that the patients were borderline needing to be intubated. So then we escalated their PPE to airborne precautions, because half the time when that happened, then the patient needed to be intubated. So everybody needed to wear an N95 mask at that point. So there were a few little things that were slightly different, and we changed on the go. And obviously in the ICU, it was similar, but the N95 mask was worn all the time with the face shields. And we did end up having problems in the ICU with the N95 masks. When you wear them for extended periods of time, caused the nursing staff and doctors to get ulcers on the top of their ears. So we were forced to, we got hold of some cloth head coverings that were laundered in the hospital to protect the ears largely. And although that's part of some of the anaesthetic guidelines, we ended up doing that largely because that was the only way that we could protect ears. And you wouldn't have ever thought about that until you set up an airborne unit, and people were wearing masks for hours and hours and hours.
For our sort of anaesthetic intubating PPE, we try to keep it as simple as possible and resist the urge to go to these very fancy PAPR sort of scenarios. It's quite a difficult thing to intubate someone in normal PPR, and we didn't want to add extra layers of complexity. So we just had a very simple, again, as long as it covered your back and your arms, 2 pairs of gloves, an N95 mask, and a face shield is all we used. And speaking to everyone who intubated a patient, they all felt that that was fine, and they all felt very safe wearing that. We tried to resist the urge to go with any of the sort of untrialed scenarios, like the intubating box seems to have been quite a common thing that people have asked about, but we didn't actually use that at all. Well, it was tried once and then not used after that, mainly because it just made the process much more difficult. And when you're sort of breathing with an N95 mask on and it's clouding up your vision and you're using a CMAX screen that you can't see properly, you don't want to add in any extra layers of complexity in that scenario. So we kept it very simple. People felt very happy, and once they'd done it, they were all very happy with it, and we didn't have any issues.
Okay, I'll just ask a couple of quick questions off the list here, sort of yes/no type things. Did your staff shower at work before leaving?
We did. A lot of the people who, if they'd been done an actual intubation, initially lots of people would go and shower afterwards. There wasn't something that we said that it was a mandated thing, but we provided the facility there for everyone to shower. And I think likewise, the nursing staff on the wards all had facility to shower afterwards as well. I think a lot of that was people didn't want to go home in the same stuff that they've been looking after these patients in.
Yeah, on the ward we didn't mandate it, but we gave them the option. But one of the things that we did mandate on the ward is that if you had to go into the isolation ward and then do work outside of the isolation ward again, then you ended up having a shower and getting changed back into your normal work gear, because we were just we were very concerned at that point about nosocomial spread.
Okay. Did were some staff eliminated due to their age or medical conditions?
We didn't exclude anybody, but we gave, before all of this happened, we sent out basically a list of conditions and age-related things that if people decided that they didn't want to participate, we gave them the option of not participating, and there was no pressure or anything like that. There was lots of people that took that offer up. It was actually the other way round though, and we found this in the pathology lab because we did exactly the same thing with our collectors. That initially we put that sort of paperwork out or the email out saying please identify yourself and blah blah blah. But after a few weeks, then people started coming back and asking to do at least in pathology, started coming back and asking to do the collecting courses and things like that, because they wanted to be part of it, which is interesting.
And in terms of your zero healthcare worker infections, is that something that's being actively followed, or that's on the basis that none of them have subsequently presented?
It's on the basis of nobody's presented. It's also on the basis that if we did have a healthcare worker associated infection, we'd probably have a big problem at the moment, and we'd be just like Bernie at this stage. But I do have a plan that's going through ethics at the moment, if the WA government lets me do it, to do some serology survey of staff members that have had, the ones that have had close contact with active cases. And so we're planning to do 100 to 150 staff members and do their serology, because we're in a really unique position, as you've already heard me say this, Andrew, but we're one of the only places in the world that had a large concentration of patients under one roof in a hospital, but didn't actually have any community or very few cases in the community and no community transmission. So we can actually do serology testing, and those results should really accurately reflect any exposure from the workplace. And we're going to control it with some historical serum specimens as well, so we can see how the assay performs too.
That'll be really interesting work. I hope that you're able to get that done. I was just going to ask you a bit on these the clinical points that you've got on the thing here about saying that the intensivists felt powerless with the patients other than ventilating them, and there's even question marks around the utility of ventilation for this disease, although it still seems to be what everywhere does. But were there other treatments given, like azithromycin or methylchloroquine, are the things that are being asked online?
No, they were given antibiotic therapy when it was indicated, but because there was quite strong ID oversight of all of the patients in the ward and also in ICU, there's actually very little antibiotics given. So they were started on the sick people and stopped very quickly when we realised that they didn't have an infection. Probably more so than normal. I mean, we're pretty good with the stewardship here, but we were actively involved with this, so it was very sort of focused stewardship. The opinion of a lot of ID physicians, not all of them, and the position statement for the Australian Society of Infectious Diseases and most colleges, as well as other infectious diseases societies, is that we don't feel that it's the right thing to give people any experimental treatment for COVID-19 outside of a randomised controlled trial. And that's something that we'd flirted in the beginning, before any trials existed, about giving people, like way back before this Artania patients turned up, about giving people Calitra and things like that. But even by the time the Artania patients, these position statements were well and truly in place, and the ID community particularly had discussions about this in Western Australia. Most of us formed the opinion that RCT was the way forward. at this stage also, the only real study that was supporting the use of hydroxychloroquine and azithromycin was a very small French study by Didier Raoult, which we obviously all read. The findings weren't particularly compelling, and there was no control group in that paper. And since basically there's been a lot of pressure for that paper to be retracted because it turned out that there are patients that passed away in ICU and things like that. I have a feeling, unfortunately, it's taken 40 years or longer to get effective antiviral therapy for things like HIV, hepatitis B, hepatitis C, and herpes viruses. I mean, to be able to turn our hand at creating either bespoke antivirals to treat this virus within a few months or repurposing existing drugs, I would love for something to work, but already we're seeing reasonable quality trials coming through that show that all of these things are systematically just not helpful and may even be harmful. Saying that, we're still part of the ASCOT trial, which is a big Australian Society of Infectious Diseases study. Most of the hospitals in Perth are part of it as well, which is looking at hydroxychloroquine and another drug called Kaletra or lopinavir, ritonavir, because we still not, even though I sound like I think that they're not going to work, the data is still not conclusive that they don't work or that they're not of benefit. And so the proper high quality studies still need to be done, and we're actively pursuing that.
Okay, thanks for that, Silke. I was wanting to pick your brain a bit as someone who's not only, super educated about these things, but you've had to make some on-the-ground decisions now as to how you're going to roll things out. So just in terms of two things, are you fit testing for the N95s for people who might be involved in aerosol generating procedures? And do you think that CPR is an aerosol generating procedure?
Yeah, so at Bethesda, we've taken the sort of approach to fit test our sort of anaesthesia response team and the COVID response team of nurses who might be involved in an aerosol generating procedure. So that's the group of patients that might deteriorate and need intubation, or potentially group of patients, for example, on a palliative unit that may be needing nebulizers and the like, so suctioning, that kind of procedure. So yes, we've taken the approach of fit testing, but I'm sure that Jonathan and David can discuss further on their approach with fit checking, and they've been very successful with that. Now, on the topic of fit testing, one further sort of comment I will make for that is that for us it was a sense of staff safety and morale in an environment where in the early days, a few weeks ago, there was a lot of uncertainty and fear and panic, and that sort of did help with sort of facilitating reassurance and a sense of the organisation taking robust steps to ensure safety. But I think Jonathan and David might want to speak more about fit checking. Now, on the topic of CPR, we've been working through that a lot over recent weeks. Our nurse educators have done a huge amount of work with our sort of MET team. And from an anaesthesia point of view, we've also sort of simulated an arrest both on the ward and an arrest in theatre of a COVID patient. Now, we are of the opinion that we're just following the guidelines from the Resus Council that CPR is an aerosol generating procedure, and therefore appropriate PPE needs to be donned prior to entering that patient's room and prior to undertaking CPR. Equally, defib is an aerosol generating procedure, and then moving one step further from that as well, high flow oxygen thought to be aerosol generating once you get past the 10 or 15 litres. So for all those reasons, we are advocating or sort of mandating that staff wear the full N95 PPE prior to sort of dealing with an arrested patient.
David, have you got Where have you landed on those kind of borderline issues around the guidelines and the AGP and the CPR?
So we've had to, all of these patients came to us quite early on when the stocks of PPE were pretty low. So just coming back to the fit testing side of things, we didn't feel that we had enough PPE that we could actually fit test everyone in the hospital, or even in theatres. So what we actually did was sort of fit tested people as they were wearing them in anger, if you like. Mainly that was coming through theatre though, because obviously running emergency theatres in a hospital where there is COVID positive patients, anyone with a temperature was being swabbed and treated as COVID for a while. We also were doing ENT surgery and emergency surgery where everyone in the theatre needed to wear N95. So we used that as a way of fit testing people. And just incidentally, what we did find was that it was quite surprising how many people actually didn't fit with an N95. And that generally were small women. Generally, the standard N95 mask does have quite a leak for quite a few of those people. And what we found is that it's quite difficult to get hold of the smaller N95 masks because they do come in a small size as well. So we are, when we identify those people, we're giving them their own individual N95 mask to keep on them at all times so that they don't have to try and find it when they need to. Regarding those sort of the guidelines with aerosol generating procedures, we've had numerous discussions about that, and the document that keeps coming out from WA Health keeps being amended. So we're just trying to be as pragmatic as possible, really. And we're doing what we can in order to preserve the PPE. So we did go down the route of testing patients initially so that we would know in advance and didn't need to waste PPE. Regarding the actual procedures, we are just sort of following the health department guidelines at the moment, which are becoming fewer and fewer procedures, which I think is correct. I think what we're beginning to realize is that this is more of a droplet-borne, droplet-transmitted virus than an aerosol-generating one. So it's becoming an issue in theatres for ENT surgery and things like that. That's where it's becoming a problem.
Thank you for that. I'm hoping that, as time goes by, the supplies of PPE will become so great and the knowledge around transmission will become so good that we will all relax a bit about it. One interesting thing I'll be interested in your view on, Jonathan, out of the Burnie experience is that the 80 healthcare workers who contracted the virus in that facility, they're saying that only about 20 of them got it from patients. Only 20. It's still quite a lot. But in terms of protecting staff from other staff, because they contracted it at work, but the majority of them got it from other staff members. Is this something that we haven't really thought enough about in our processes? Because we tend to talk about those interactions with the patients and not so much with staff and, as you said, the surfaces and the contact areas within the facility.
Yeah, I think this is actually my biggest concern about this virus. And there's a paper that was only published a few weeks ago in New England Journal of Medicine. It was a pre-symptomatic transmission of coronavirus in a skilled nursing facility, which I read as a nursing home type facility. And about 67 cases, I think, were identified in a nursing home. But 50% of the cases, so half of those cases, were identified by PCR when they were pre-symptomatic, so before they had symptoms, and then subsequently they all developed symptoms about day 4 from when they were swabbed, and those were very strong. When you read the paper, they're quite strong detections by PCR. It's not a viral culture study. So you don't know just how much viable virus there is. That's one weakness of the PCR study. But you would assume when it's a strong detection that there's viable virus there. And you kind of extrapolate from that when you diagnose patient number 1, and we're talking in a nursing home, we're talking the first staff member, at that stage, you may well have a much greater problem on your hands, because potentially those patients or those staff members or whoever it is, they may be transmitting the virus. But I think it's as important to think about this virus as being spread by going that as it is by talking, coughing, because these pre-symptomatic people, they're not coughing. They don't have any respiratory symptoms, so they're not really creating that many droplets. And you can say that when someone talks, they do spit a little bit in many cases, but usually the droplets they don't go that far, which is really why the government's pushing the 1.5 metre social distancing rules, because that sort of takes that into account. But it's the hand hygiene and it's the contact with the face and the shaking of the hands and all of that, which is probably a huge risk. And currently, as we've talked about, Andrew, before, in the context of one of these outbreaks, it's currently illegal.
Attention visitors.
Sorry.
Please be aware, visiting hours.
Visiting hours are closed.
You guys never go home, I know that.
But you'd be aware that it's currently illegal to screen an asymptomatic person, which, I mean, I think is reasonable for a low risk scenario where there's no reason to do it. But I would like to be able to, in the setting of a nursing home outbreak, to just go through the nursing home and screen all of the people. And I think that's going to probably happen in the future.
Yeah, I think we'll get there. Like PPE testing was jealously guarded at the start, and hopefully, you know, once we all relax a bit and understand what's going on, I'm not going to get a $20,000 fine for wanting to order the test on someone who looks crook, but not in the classic COVID way. Quick question for you, Silke. If I gave you an unlimited budget, could you turn PMH into a pandemic hospital anytime soon? Or having seen what you've seen and been through what you've been through, do you think that adapting facilities is not as easy as saying there's a empty carcass of a building, go and do it?
Yeah, look, I think the spatial challenges are certainly one thing, but it's more about the workforce, the operation, the supply, you know, the communications. They're the sort of 4 big pillars that we've organised our approach upon, and workforce is a big part of it, and policy, obviously, that I alluded to before, those administrative hazard controls. So, you know, designing a building or redesigning a hospital space is one thing, but I think it's an entire institutional approach. So I think that would be a very difficult thing to do. Who knows though? I've learnt over time that this town is capable of amazing collaboration and resilience, and has built a culture of real care for each other and our patients. So I sort of think at the moment anything's possible. We're obviously winning this from a public health perspective, but there's been a huge amount of silver lining for me in just kind of collaborating and learning from my colleagues at different hospitals and the WA health community coming together. So, I mean, on the topic of the actual hospital spaces, there's a fantastic article that was released just this week, collaboration between a couple of Boston groups, Ariadne Labs, which is a Harvard affiliated healthcare sort of think tank, together with the Mass Design Group. We can put the link on the follow-up email that Lizette will send tomorrow, but it's a really good article on redesigning hospital spaces on the fly. And it's based on some work that was done in New York at Mount Sinai Hospital, and probably even more applicable to hospitals with lower resources. So that's something to think about with regards to the spaces. And with regards to PMH, I'm not sure, but I'm sort of thinking anything is possible.
Thanks. Probably the asbestos would be a bigger risk than the virus. And a question for Joondalup, in terms of having had that experience now, how well do you think the hospital would cope with its business as usual alongside a significant COVID patient load that was there on an ongoing basis from the community?
I think we're really, really well placed at the moment, actually. In fact, we're sort of desperate for more work at the moment. You know, we've got a third of our theatres taken out at the moment, but we've already got plans. I think we were lucky again because all our patients got better. And then since then, we've been coming up with plans to be able to reintroduce our normal workload. And I think we're all set and ready to go really for the increase in elective surgery. And we can easily flip back to where we were previously when we had a lot of sick patients. I think that's the best. We now have plans to flip from one side to the other very, very easily.
I'm going to say that spoken like a true anaesthetist in that, although
we're not
that's all.
Opinions,
The people have started coming out of the woodwork. They were scared to come to hospital for their medical problems now. The cardiologists have got heaps of patients, more than really the capacity is in the hospital. The little old ladies and little old men with their big issues are starting to turn up at the hospital. So medicine's kind of getting busy again. I'm starting to get more consults. So the risk that we've got is the business as usual medical from medicine, because during all of the problems that we had, no one was turning up to hospitals. ED was like running at, what was it? Like
30%.
Yeah, 60% or less capacity of normal, and that was because people were scared to come to hospital. I mean, we've done a fantastic job in Western Australia. People are stuffing themselves on the back, and I mean, you credit where credit's due. Some of it's to do with you, Andrew. But the problem that we've got now is that we've done such a good job. Everyone's going to start coming back to the hospital. The fear is gone, and if we did have a problem, I think that if we're not careful to make sure that we maintain some of the infrastructure and some of the expertise, which we're grateful that Joondalup has continued to sort of allow us to have a COVID isolation unit operating with respiratory physicians running it, perhaps a little bit more like general physicians, but the respiratory physicians do assure me that they're enjoying some of the general medicine that they're doing. Well, I think we're lucky that we're about to do that. But I think we're, yeah, I still have grave concerns about the direction which this could go. And as you can see, all it takes is one patient, one nursing home, one flight of patients, one cruise ship is enough to put us back to day dot again.
Absolutely.
If I may.
Yeah.
The business as usual dialogue has consumed much of our conversations this week, especially with elective surgery reintroduction. And you know, look, in some respects, I've just had a chat with Fiona Lake about this today, actually, that, you know, the brakes on our healthcare system are on so strongly that we're because of the fear of what may happen, reluctant to sort of let go and, you know, start to cater for some of those patients that are now presenting and needing their surgery. So it's going to be a very fine balance, and certainly, you know, we've dedicated areas at Bethesda, similar to you guys at Joondalup, that are sort of dedicated for COVID responses, but trying to find that balance now between, you know, keeping those areas and spaces dedicated for COVID, but managing to perform safe and efficient healthcare is going to be an important discussion as we go forward, and everyone recognises that. And whether that means, you know, for example, for us, whether more of our, you know, we're sort of continuing to do more of what we're good at, which is elective surgery, and sort of ensuring that that, you know, COVID patients might be sort of transferred at an early stage and kept at institutions that are specific to that is probably going to be the approach going forward, I think, because we need to think about this business as usual scenario.
Yes, and we did have I'll wrap up now and say the thank yous, but we did have a very productive discussion between the AMA, WA Council, the Chief Health Officer, the Director General, Christopher Blythe, and also with Liz McLeod last night, about how we now have to, part of it's about how we now have to adapt and customise what we do in Western Australia because of our success, because the path that we really didn't want to go down, you know, by virtue of our our travel restrictions and our social controls, we managed to avoid that. Now we have to figure out how to live for a while and how to adapt the system in this flexible way so that we can expand or reduce capacity. The areas we worry about, obviously, not only the nursing homes and hospitals, but the regions, you know, so vulnerable. 600 ICU bed capacity we will have in Western Australia when the plans are complete. Less than 10 of them will be outside the metro area. So this is obviously a plan for transportation, and from everything I hear from you guys at Joondalup, you don't necessarily have the time to move people who are starting to deteriorate, and these people don't do well when you move them around. So lots of challenges to come. Really appreciate the expertise, even from the non-anaesthetist on the panel, who I thought was a very good sport tonight to turn up in the face of the intimidating intellect of sitting alongside even just one anaesthetist, but having two more on the video must have been very difficult for you as a physician, Jonathan. And a pathologist. Very I do want to thank you for your expertise. Congratulations on all of your good work. Thank you so much. It makes us all feel more reassured that we can come to people like yourselves for advice as we go through it, work together as a community and learn a lot. I'm sorry to the people online if I didn't get to your questions amongst the many. I tried to consolidate some together. If you didn't recognise yours, it's because I combined it with another one. AMA will be putting on lots more of these webinars around this and other things that practitioners find interesting, because I think it's a convenient way to live and have a good chat about something with some very intelligent people, as we were lucky to have with our panelists tonight. So thank you very much. Good night from the AMA, and we'll catch you again soon. Please email us with other questions and we'll try and follow them up for you. Thanks a lot.
Thanks, everyone.
Thank you.
Good night.
My hand on the screen.